Greg, you want to start us off here with our welcome?
Yes. Welcome, welcome, welcome. Welcome, everybody, to the Emergency IDNet. We're going to launch this project, the CRASHED project, the cause of rashes in the emergency department. So I'm just going to give you a little bit of background, some inspirational words, hopefully, to give you some context for this project, where it's coming from, and what our thoughts are on putting it together. So, probably everybody on here will remember a few months ago when we kind of all of a sudden were faced with seeing this disease that most of us had never, ever seen before, ever in our lives. Even though it's been endemic in Africa, there have been a few sporadic little tiny clusters of cases that had happened in the US over the years. It had been many years since we'd had any actual cases in the United States. But this disease just suddenly kind of exploded. There was a big cluster, several outbreaks in multiple places across the United States. But it was very different than the traditional epidemiology of monkeypox, which was largely in Africa. It's a zoonotic infection. Occasionally there would be some cases that would spill over into the human population. They would usually, have a small area of spread, mostly in, little villages here and there in Western Africa. And then largely, they would die out there, but there would be some areas where it would come up periodically. This was largely driven in the US cases that we saw, and the cases that were seen in Europe and a lot of other places throughout the year. It was largely spreading in the population of men who have sex with men. There were a couple of large festivals where there were, a lot of contacts from people flying in from places all over the world, were exposed there and then brought it back. So then there were these various clusters that occurred in a number of places in the world. The epidemiology was largely that it was sexually transmitted. Now, even though this isn't strictly a sexually transmitted disease, that was largely the context in which it was spread, not so much specifically from sexual contact, but it's kind of hard to have sexual contact without having skin contact and touching people. And so that was the epidemiology in which it was spread in that cluster. And really, as quickly as it came up, it blew up pretty quickly over really a matter of weeks. And pretty much just as quickly, over a matter of weeks, it kind of faded away again. I know we were seeing several cases a week in our emergency department. Carl Berldahl, who's been part of the team who put this project together, works at Cedars. They saw quite a few cases in their emergency department. And largely through some public health interventions, largely there was a very big educational effort that was aimed largely at the gay population where this was spreading. They had vaccination campaigns, kind of risk mitigation education as to how people could avoid this. And it actually worked. It went away. We haven't had any cases in our emergency department in several months now, but there are still some pockets in which it has still had a few sporadic cases in the United States. So it hasn't completely gone away. And so we thought this network that we have would be the perfect place to do ongoing surveillance, looking for this. The CDC does think it's likely that we're going to see some occasional little clusters popping up here and there. And we don't know if it's going to follow the same epidemiology. Maybe it will still remain, largely related to sexual contacts. Maybe that epidemiology will change. Maybe we need to broaden our screening a little bit to try to look for it in maybe other populations in which the epidemiology of it may be changing. And maybe it won't pop up. Maybe we'll find that maybe it is really gone. That would be very valuable information to have too. But we thought that our network is really well set up to look at these cases when they come up. They very often will present to emergency departments. Some of them will go to sexually transmitted infection clinics, kinds of things, but a lot of them will be coming to emergency departments. And that's why we thought we would be the perfect place to do this. So CDC is very interested in this project. They do still see Mpox as a priority, and they've given us funding to try to do this. And they think this is a very important project, and we want to make sure it's successful. Now, you will note that it doesn't say Mpox anywhere in the title of this project, and we did that very intentionally. We really don't want people to see this as an Mpox project because we don't want people to think we're looking specifically for people who had the epidemiologic risks, the epidemiologic exposures that we saw in these Mpox clusters a few months ago. So we're calling it a rash project. We want to screen for people who have rashes that could potentially be compatible with Mpox. Those are the patients that we want to screen. We know full well going into this that we will be enrolling many people who there is no way they have Mpox. We have very low suspicion that they have Mpox, but we're intentionally casting a broad net because we want to make sure we don't miss those atypical cases. We don't miss the cases that might not fit the typical epidemiology of these recent clusters in the United States. And that's why you'll see how we're kind of designing this project, and that's the way that it's set up. So that's my quick spiel.
Thanks, Greg. All right, I'm going to be driving here the rest of the agenda, but I have a lot of help. We have Carl Berdahl, who Greg introduced, who's going to talk about background and eligibility. I'll be going over screening and enrollment. Dr. Jesus Torres will be going through the data collection forms. Kavita Patbaraja will talk about image capture and specimen collection. Our REDCap manager, Lorenzo Duverne, will go through a brief description of the REDCap. And then I'll be back to talk about the audit and some communication. So I'll stop after each of these sections for questions. That's a lot to cover, but I think we might be able to fit this in an hour. So let's go ahead and start. I wanted to first most of you all know the main players here. You guys know Dave, you guys know Greg, you know Bill, you know me, you know Kavita, but I wanted to introduce, and you guys may know Jesus Torres. He actually started with us a long time ago as a research coordinator, and now has gone up the ranks and is beyond successful, and is now UCLA attending emergency medicine and a researcher as well. So we are lucky that we still have him around. And he's one of our core team members. He's the one who worked on the data collection forms primarily. Lorenzo Duverne is our REDCap manager. He's one of the senior research coordinators at Ronald Reagan UCLA, and he's the one who's helped us develop the REDCap and will be managing access to it. So you should definitely know his name. And then Carl Berdahl, as Greg mentioned, he is an emergency physician and a researcher at Cedars-Sinai Medical Center. And so they're going to be included in this surveillance. And he's the one who wrote the protocol for this project. Before I turn it over to Carl, I just wanted to, put this in here. I know these are the 13 sites involved, and some of us are all good with our IRB and our subcontracts. So for the most part, we're almost there. We have 3 sites that don't have IRB determinations yet, and 3 sites with subcontracts yet. So I really want to just go through here really quickly. I know, Jill, I saw you on, so I don't have to bug you by email later. Have you heard from your IRB?
Yeah, actually, I was just about to reply in the chat as well. Hopkins IRB is reviewing today, and ours is actually supposed to be getting reviewed today as well.
Okay.
So hopefully I'll know by either end of today or end of Tuesday.
Okay, great. And then Gabby already put in the latest for Hopkins. Mastura, I think you're on. Do you know the update for OHSU?
No, I'm sorry, I don't. The ED department is taking care of the IRB. I haven't heard back, but they do. The IRB, the last that I heard was they were wanting a document. I'm sorry. I don't have an update for you, but I need to look into it further, and I can get back to you after this meeting.
Okay, sounds good. And thanks for joining. Is Anik on? I know that she's also.
No,
She's not on.
I don't think she is.
Okay. And then Brett, I already have bugged Julie a lot, so I know that it's in process. And your subcontract, I mean. And then Utsav, I've also been in contact with Callie, so I know that those are progressing as well. All right. Well, with no further ado, I'd like to transfer it over to Carl Berdahl to go over the background.
Great. Thanks, Anusha. Thanks, everyone, for being here. I'll go quickly through the background since we've already covered some of this. But as you all know, there was a big surge last year of this virus, which had been endemic to Africa and then made its jump. And, locally at Cedars-Sinai, and we're just down the road from UCLA, we saw about 200 cases in the ED. And in fact, we had our tents still set up, our surge tents from all the COVID surges we had previously had. And we had enough cases that we were using those same tents to take care of these patients. So that's one of the things that led us to get involved with the network because we really wanted to do something in the event that this reoccurred. Next slide, please. So what is the typical course of monkeypox? This is all taken from the CDC website where, contact with an infected person occurs, again, typically during sexual contact. And then there's a 3 to 17-day incubation period without any symptoms. That's a long incubation period compared to most viruses. Most typically, a rash is the first symptom that starts, and this can be hands, feet, chest, face, or mouth, or near the genitals. And then many patients also have flu-like symptoms. But presentations are different among different people. Some have flu-like symptoms before the rash. Some have a rash first and then get flu-like symptoms later, and some only get a rash. So the presentation can easily be missed, I think, if we're not vigilant for this in the ED, which is one of the reasons it's important to know what's going on in the community. So that's where our project comes in. Next slide. So, we have mentioned that a lot of us have sort of seen this disappear from our EDs, and by sort of, I mean actually disappear. But we wonder if we might be missing some of these edge cases, some of the atypical presentations, which is why we're asking you to enroll a broad swaths of patients. There also have been reports of breakthrough infections. So I think we have another slide on this, but in Chicago, there was a recent outbreak where they had about 12 cases at the same medical center, many of which were breakthrough cases, meaning in patients who even got vaccinated last year. So high-risk patients got vaccinated and now this year had a breakthrough infection. So we may start seeing sort of like COVID, right? Where if you're vaccinated, you may have a milder case. We certainly may be seeing similar such presentations this year, then placing those who are exposed who've not been vaccinated, at potentially higher risk. Next slide. Yeah, this is a slide showing that this was very recent. This outbreak in Chicago was last month, where they had the cluster of cases. So the CDC, Anusha, correct me if I'm wrong, they reached out to us and said, do you guys have any sites in Chicago?
Yep.
Yeah, hopefully you have some sites in Chicago, which we do not. But if we're in close contact with them and they're really curious to see the outcome of our study, which is why we're excited to get started very soon, as soon as possible. Next slide. This is designed as a multi-center prospective surveillance project. So, enrolling patients as we see them and then following them over time. So our objectives are really to determine the prevalence of Mpox among patients with any skin rash that could be compatible with Mpox in the ED population, to then among patients who test positive to describe their presenting symptoms and signs, since things may have changed in terms of the presentation symptoms since last year, and to characterize community risk factors as well as patients' health outcomes. So there's a protocol in place for following patients over time. So who are we looking for? Almost anyone with a compatible rash, okay? So ED patients greater than or equal to 3 months of age. So nursing home patients, for example, could be at risk due to close contact in their living situation. So we're really enrolling almost anyone greater than or 3 months old in age, and that has any skin lesion that appears pustular, vesicular, crusted, or ulcerated. And we'll show some pictures on some subsequent slides. In terms of exclusion criteria, people who've already been enrolled in the study, we would not want to enroll a second time. And then if your institution like ours has exclusion criteria for things like break the glass in EPIC or opt out from research, those would be reasons to exclude them. We are only able to enroll those who speak English or Spanish, just based on the fact we have a lot of questions on our surveys that have been translated into Spanish. So other languages we're not able to enroll, and patients who are unable to consent, we are also unable to enroll. So now here are some gross pictures. So pustular rashes, vesicular or bullous would be eligible. So this is an example of a pustular rash that looks fairly bullous in nature. So pustular means it has pus on the inside. That's what that yellow stuff is, and it's raised up almost like a bubble, which is sort of what vesicular or bullous refers to. Here's a little bit more atypical lesion, but I actually saw a case that looked very much like this last year, where it was one pustule. So a person with this one pustule would be eligible. The rash then at later stages can take on a different appearance as the lesions sort of age and become crusted like these lesions. And then erosive. So at a further stage, you may see some erosive character to the rash. And some of you may be thinking, this looks like a patient with really bad venous stasis dermatitis. It might. So we are considering these patients eligible if they have rashes that appear like this. And then finally, ulcerated, where it's kind of punched out. Yeah, these we also consider eligible.
All right. Thanks, Carl. Does anyone have any questions for Carl before we move on?
I just had a quick one. I'm assuming you don't want us to enroll something that seems like a pretty obvious abscess, the larger one, at least, but I guess I just wanted to clarify that.
Yeah, Greg, feel free to weigh in on this one too. But yeah, I think we're trying to stick to these kind of more localized skin rashes. Yeah, Greg, do you have thoughts on that? You're muted.
We lost Greg. But yeah, I think we are. So I don't think this includes an abscess.
Yeah. So that is an excellent question. And for our site PIs, I will tell you right now, you're going to get a lot of questions, at least initially, about, oh, you know, what types of lesions would really qualify or would not. Technically, you're right. I mean, technically speaking, a single abscess could be considered to meet the criteria, but we don't want, I mean, I think people can generally distinguish a simple skin abscess than a rash. Now, if there's a cluster of smaller things that look like abscesses, I mean, if you look at, you know, some of those pictures that Carl already showed, you know, you could consider some of these, if you look at it as an individual thing, could look maybe like a small abscess. I mean, one of those pictures that Carl showed looked like just a simple zit, you know, I mean, that could be just a simple zit, you know, nothing else. And I don't think we would want to enroll everybody with a zit, you know, somebody who has acne and has a bunch of acne lesions on their face that, you know, with known acne and it's kind of the same thing they've had. I don't think we need to enroll that. But if there's a cluster of them, and especially if it's associated with any other, you know, types of systemic symptoms, then yes, they would. We know that because skin lesions can vary in how they present, this is something that is going to take a little bit of a judgment call. And you may want to, at least early on when you're launching this study, you know, make sure that you've got somebody available to kind of, you know, maybe field some of these questions in real time about whether these would qualify and whether you want to enroll them. We would rather err on the side of over-enrolling than under-enrolling. So if we enroll an occasional abscess here and there, you know, just like simple skin abscess that's probably staph and you're just going to IND and send them home, that it would be okay if we enroll some of those people. Again, we'd rather cast a broader net than miss some. But the intention is not to enroll somebody with a zit, acne, a simple skin abscess, but we know we will enroll some people, like I'd said before, who we are pretty confident of what the diagnosis is. You know, shingles, for example. We had a patient, one of our very early enrolled patients here at All of You, we were confident had shingles. This individual also had some disseminated lesions. It wasn't just a dermatomal thing. We did enroll that patient, pretty confident that it was shingles. That's okay. And even if your staff are pretty confident that they have a diagnosis that is not Mpox, okay to still enroll them.
Yeah, I think that's exactly right. And especially early on, while you're getting used to the enrollment procedure and everything, I think there's a lot of value to getting some practice too. So, yeah, great points.
Go ahead, Mestra.
I just have a question. Do these lesions present similar in children?
So
Generally, yes. I mean, in generally speaking, yes. I mean, I can't say I have a lot of experience seeing Mpox in kids. We did have at least one pediatric case at our hospital back in the cluster last year. But generally speaking, yes, they would still present as falling under our enrollment criteria.
Thanks.
All right, anyone else? All right, we'll keep going. So I'm going to go over screening and enrollment. And as we've been talking about is we are looking sort of as broad as possible. We tried to, though, come up with some chief complaints that would minimize the amount of work that you would have to do and minimize the number of charts you would have to look through. We have chief complaint of skin rash, lesion, skin ulcer, sexually transmitted infection, fever, chills, pain in genital or anal region. So as usual, you would review the triage and nursing notes, definitely talk to the treating clinician, and you confirm in eligibility. And as Greg mentioned, and Carl mentioned as well, I think it's really good initially to go down to the ED and look at these rashes. So that, I think by the end of the project, all of you will be experts in rashes, as we all get to, you guys now, Emergency ID Net sites are experts in skin and soft tissue infections, UTIs, septic arthritis, diverticulitis. So now it's time to get really knowledgeable about rashes. So even if they say it's probably not eligible, if they're not sure, it's always good to go check. And what we have set up is, a text communication with Greg and Dave and Carl and Jesus. And basically the study coordinators will just take a quick picture of it and show it to the group so that they can kind of weigh in as well, just to see whether this could potentially qualify. There was one that we had in the pilot that we ended up enrolling, but it turned out it was more of it may or may have been like kind of on the line in terms of enrollment. But again, we want to cast a broad net, but we also don't want to enroll a bunch of things that probably don't qualify either. But I think as we get more experience, it'll be more clear what we're looking for. As usual, we want to put posters, flyers up in the ED doc room and information on who to contact, call us for rash. Do not put Mpox on the flyer. And then as usual, we want regular announcements to our staff so that they don't forget to call us. Also, please set up back screening for your non-coverage hours of missed eligible cases. And then if a patient is admitted, you can still approach them for enrollment.
Go ahead.
Here's an example of the poster that our team put together for the project. So it's very eye-catching, as you can see. And so if you can blow this up and put this in your ED, I think this would help. This is on the website. So if you want to download it and alter it for your use, it's available there. Anything you want to add?
Yeah, I was just going to give you a little bit of a marketing tip for your site. I mean, we have these posters that we put up. We did, when we were launching the study, we brought in donuts into the emergency department, as we often do. Do not forget to enroll. we put this picture on the donut boxes. I don't recommend that you do that. That did not go over well.
Yeah, that's gross. All right, so as usual, you guys have seen screening logs, so this is also in the MOP, but make sure that we're including in the screening log, it'll be anyone with a rash. And all of you, honestly, we've been screening now for about 7 weeks, and we've enrolled 5 patients. That's much less than we expected. And, you know, it's just because we're not seeing a lot of rashes, one, and then the other is that it's usually the rash doesn't qualify. As you can see, like there, it's not pustular, vesicular, ulcerated. So we are definitely seeing less than we expected. So we're curious to know what your experience is with this. But for now, we're just limiting it for if there's a rash on the chart or the clinician says there's a rash, that they go on the screening log. And then make sure that when you approach the patients, you have everything ready. There's a list of all the materials in the MOP, so just go through that checklist. Make sure you talk to the clinician before you approach the patient. We are including prisoners and vulnerable patients, but again, you know, you want to check with your clinician. It may be sort of a case-by-case basis as to whether you can approach. We know that follow-up is not always possible in these populations, especially if they're homeless or prisoners. That's okay. I think we still want to capture them at enrollment. If there's a way for us to get an alternate contact or something like that, where we can reach out to them and get them at the 45 days, then we would do that. But otherwise, we would be okay with just enrolling. Sites are probably going to ask me about compensation for prisoners. Again, that might be a case-by-case situation. Obviously, you can't hand some prisoners cash. You may be able to send it to one of their relatives or a gift card or something like that. So definitely reach out to your site PI or your team for guidance when these cases come up. So again, that chat is always a group chat or some kind of texting in real time is always good to have. We've used that for many studies now, and it's been really invaluable with the screening process. You know, this is one of the first times we've enrolled patients that are more involved, you know, it's a more sensitive population. So we want to just remind you all, I don't think I really need to, but just remind you all to be sensitive. And again, make sure you talk to the clinician before you approach and make sure it's okay to move forward. And then remind them that they don't have to answer all the questions that if they're not comfortable answering. The enrollment survey, if you haven't looked at it yet, has some more sensitive questions about sexual behavior and contacts. So again, if they're not comfortable answering, they can always an option to decline to answer and skip the question. Well, we're going to ask for written informed consent. I know this is public health surveillance. It's not required. We just felt for this project, just given the sensitive nature, we wanted to get written consent and assent for the kids. So for kids 8 to 17, we get assent from the participant, and then the parent still signs the informed consent form. For ages less than 8, it's just the parent who gives consent. Make sure you give a copy to the participant and then keep all of that information secure at your site. So we're not going to need that information. You're not going to share that with us. And also the participant contact information form, you're going to keep at your site. You're not entering any identifying information into the REDCap. One thing that we want to do, if a participant is positive for Mpox and seeks care for that illness, including if they go to an outside facility, and this is through 90 days, we want to try to capture that. So what we usually do for our studies is we have them sign the medical record release information form up front at enrollment. And then if the participant does not test positive for Mpox, then you just go ahead and shred the form. So you don't have to worry about it. So this will probably be for most cases. You won't end up using this form, but just to make it easy that, later on, if you find out at the telephone follow-up that they went to an urgent care nearby, you'll be able to just use this form easily and get those records. At enrollment, you'll assign a project ID. And so this is just the initials of your institution, and then followed by MP for monkeypox or Mpox. And then we're just numbering it starting with 001. So this is the standard emergency IDNet numbering. Before I move on to turn it over to Jesus to go over data collection forms, is there any questions about screening and enrollment?
I had something to note. Most of our patients at the University of New Mexico, at least from my preliminary look at what types of patients are going to be eligible, the vast majority of them are between the ages of about 4 and 8 years old, just based on reason for visit. So I know that there are probably plenty of rashes coming in through our adult emergency department, but I wanted to what sort of key terms might we be looking for among adult patients who present that may be eligible? I mean, other than rash, of course.
Yeah, I think rash is the main one. It does seem like there's quite a bit of variability in terms of the case mix that people are seeing at their EDs. But yeah, rash is the main one that I would expect. Sometimes there might be, sexually transmitted infection related chief complaints, but rash is really the main one.
Okay.
But given the epidemiology of the most recent outbreaks in the US, we're also looking at people who come when, it may be a chief complaint of rectal pain or, genital lesion, or, it might be something like that. So I would suggest that you kind of screen for those as well. Now, a lot of those are going to be a hemorrhoid or a perirectal abscess or something that won't qualify. But again, in terms of just kind of screening, yeah. And, if you're tracking on your board and looking for complaints, that might be something to just, do a quick check with the provider to see if they might qualify. Those would be things that would be worth looking at also.
Yeah, and you might, as time goes on, get a feel for what works and what doesn't. And we'll talk a little bit about the audit later. We'll talk about ICD-10 codes. But we did enroll a patient here at All of You whose chief complaint was ear pain. So that one, again, that's why it's really important that you talk to the clinicians ahead of time and make sure that they're looking for rashes as well, and that they call you if they see it. Also, maybe the triage nurses or something like that. You want to make sure that you put up the posters, flyers, and have them contact you, because it's not always simple, as you know, Silas.
Thanks.
And then another thing about kids is, sometimes they have, like, common one that has come through my house like 40 times is hand, foot, and mouth, right? So you'll see ulcers. They may have it, on their hands, in their mouth, and on their butt, so and those would probably be eligible, and we would want to enroll those too. So again, this is a broad net, and even if you know that this child most likely doesn't have Mpox, we want to enroll them and capture, if there is something going on, we want to be broad with our enrollment. All right, I'm going to turn it over to Dr. Jesus Torres.
All right, thank you, Anusha. Thank you for having me here. So I'm going to talk about data collection forms, and hopefully we can make some sense out of it, because it seems like there's a lot of forms and it's pretty complicated, but hopefully after this overview, we could sort of break it down for you. I would say off the bat that Anusha has put a great website with all the latest and greatest versions of our forms. So we'll refer you to that as well. So essentially, the way I see these forms is breaking into sort of 3 columns or 3 buckets, if you will. Your enrollment that everybody's going to get, day 45 that also everybody's going to get, and day 90 that some people are going to get. And we'll talk about that as well. So let's talk about enrollment first. And next slide. So the very first important form that we should talk about is your contact information form. This is obviously the form where you're going to get the participants' contact information. Again, we are also enrolling patients that may not have a cell phone or an address, but we are interested in those vulnerable populations, especially the homeless. So I would encourage you to get any type of contact information, a cell phone, an email address, their mom's telephone, anything will be important, but would not keep them out of the study if they don't have any of this information. Next slide. The enrollment form itself actually comes in two categories or 2 forms, if you will. One that all ages are going to get, and this is it. And then the other one that those that are 16 and over are going to get, and those have the sensitive questions. For the all ages, the one that everybody's going to get, the first 9 questions are the clinician questions. So when you're enrolling a patient, it's kind of easy to just hand this to the clinician and have them fill it out. It'll be the first page. And then if next slide, or this is our, I just want to kind of blow this up, show our homunculus that shows the locations of where the lesions might be. And for example, 1R head anterior right, pretty specific, but I want to point out that in REDCap, there'll be a drop-down arrow that you could add the specific locations of where the lesions were swabbed. Next. For our 16 and over, the self-administered, and next one more time, has all of our sensitive questions. And this is, again, one more time, Anusha, next. This is a confidential part of the survey. Actually, all of our surveys are confidential, but this one specifically, they ask a lot of the sexual identity and gender identity questions as well. They do have the option to opt out of any questions that they don't want to answer. We do have the option of giving them an iPad or a tablet to where they could fill out the questionnaire or even a paper questionnaire for some of our older patients that don't have, experience with technology. I will point out, though, that this is kind of sensitive, so we will have the study team exit the room, give the patient or the participant privacy, but be nearby to answer some of these questions. And the reason I say that, because in our Spanish form, the word heterosexual doesn't really translate. And for example, I had my mom take this survey and she asked me questions about what that word meant. So we had to have that conversation. Next slide. Next slide, yeah. At about 96 hours, we're going to do an EMR form. Next. And this is what the EMR form looks like. And the reason why we do this is because sometimes when we enroll patients, clinicians might send a GC chlamydia. It will take a couple of days to result. So we want to wait at least 96 hours or so to be able to capture that data. Next. So this form here, I want you to keep a close eye on, is the one with a bunch of little boxes. This is the test results and follow-up. And the reason I say that is that this form kind of appears throughout the rest of the time periods. And this is a form that you're going to start recording some of the follow-ups of day 45, possibly day 90, but also your test results. Now, when we send the swabs, you're not going to get the results in real time. We're actually going to batch them in our laboratory, and you'll get the results weeks later. So this form you should start looking at this form after enrollment through day 45. Once you start getting the laboratory results data back, you can start filling out this form. Next. So now day 45 of the follow-up, again, this includes everyone, and it includes with the first form will be a telephone follow-up. Next. And one more time, yeah. So telephone follow-up, this is what it looks like. And one more time, next. At the end of the telephone follow-up, there's some sensitive questions that I just wanted to bring up. For example, vaccine and so forth that they potentially received. And next. And what we're sort of entertaining as well, some of our patients we won't be able to contact just like any other studies. So after 3 unsuccessful tries, we're thinking about coming up with an additional sort of layer, and that will be to generate, REDCap will generate a link that we'll be able to text or potential email to some of our patients as well. Then hopefully we could capture them as well during that method. More to come on that. And here we have that form again, the test results and follow-up form, the one with a bunch of boxes. It shows up on day 45 with additional questions that you should fill out and prompts you. Next. And those that are positive, so the majority will probably be negative. Some, we hope, will be positive. And those that are positive at day 45, and they had either additional testing or some sort of health visits that are related to Mpox, if they do have that, then that would trigger your health care utilization form. Next. And this is what that form looks like. Again, this is for Mpox related healthcare visits. So like say, for example, they were positive in our initial enrollment and they came back because of a sprained ankle, that doesn't qualify for this. However, if they came back because they had a superimpulse infection or they had ongoing symptoms or ongoing pain, and they're seeking additional care for that, Mpox related care visit will qualify. Finally, day 90 follow-up. Very few people likely will fall in this category. Next. And next. A couple more times. Yeah, so this will be at day 45. There's a question in our enrollment, in our test results and follow-up form. Participants that are positive at day 45 and during that follow-up visit, they still experience some symptoms, then we're going to follow those to day 90. And next. And again, this is the test result and follow-up form that appears again. This is their follow-up form at day 90. And if they're having symptoms, they will also trigger another healthcare utilization form. And that's it. This is what it looks like. And hopefully that makes sense. If not, feel free to reach out to us.
We tried to make it a little simpler with that one test results and follow-up form. So it's kind of like, it kind of puts it all together and it's sort of like a tracker for you. And then it sort of shows you where to go in certain instances and when to stop. So I hope, we hope that actually helps and doesn't confuse you guys more, but I'm sure you'll let us know.
Any
All right.
Actually, I just want to make sure any questions on this, because I know this could be a little confusing about, the who is going to go to the 90-day follow-up, et cetera. It should be a very, very, very tiny group of people who will go to the 90-day follow-up. Remember, it's only those that tested positive for Mpox and are still having symptoms. So that should be a very small group. But we do want to do up to the 45-day follow-up for everyone. Is that clear? Actually, let me ask a question. Are we confident that we are going to have the results from the central lab for Mpox by day 45 for everyone?
We should, because we're supposed to be sending the specimens every 2 weeks. But I will confirm that with Dr. Gardner at the lab to make sure.
And I just want to clarify also for the testing. Remember, we're casting a broad net. We're testing all these people through the central lab for Mpox. We're getting the swabs. You are still, free to do whatever testing you think is clinically relevant at your site. And you may opt, if you do have a high suspicion of Mpox, you can and should be doing your own testing as part of your routine care at the site. In other words, if this is a patient that you would clinically be sending Mpox testing for some reason based on an exposure, you already know there's some cluster in your area, something like that, we encourage people to go ahead and do that. But we'll do it for all of them through this central testing lab.
Yes, Master.
I just need one clarification. So all the people who are screened enter enrollment. Is that correct?
Well, if it turns out that they don't have a lesion that qualifies, in other words, we will screen people who don't qualify to be enrolled. But everybody who is enrolled, then yes, we would do that enrollment form and do the swab.
Got it. Thank you.
Hey, I have a quick question based on the clinician questions. Do they have to be completed by the attending or it can be a resident as well?
I think either could be completed.
Okay, sounds good. Thank you.
Yeah, this gets a little bit difficult. Like, let's say the patient gets admitted and you approach them the next day to track down the clinician. You may need to just talk to the admitting clinician and get the answers to those questions. So this could get a little difficult, but hopefully you can find whoever treated them in the ED and get these.
Right.
It is a timing thing too, right?
Yeah. Right. Thanks.
Yeah, sometimes we don't get to ask them those questions and we end up like emailing them and asking them retrospectively sometimes, but as much as possible, we need them to actually be looking at the lesions because we ask about measurements and things like that. Any other questions? Okay, I'm going to keep going because it's already 10:48. All right. So let's turn it over to Kavita to go over image capture and a rash swab collection.
Okay, so I'm going to talk about taking photos of the lesions. So these are some points just to prepare for the photo. You want to make sure that you remove any personal identifiers such as glasses, jewelry, etc. Pull aside their clothing so that, it doesn't distract from the photo that's being taken. Avoid photos of tattoos unless, of course, that they're part of that lesion. Attempt to take a photo against a solid or neutral background. I know that's not always easy to do, but, if there's a wall or something, that might be helpful. Use natural light if available. So you're going to take 2 photos of each lesion location. So the first photo, you want to make sure it's kind of like a distant shot, so it shows the whole extent of the rash. And then the second photo will be a close-up to show the details, but it's good to include some normal nearby skin if possible so that you can have something to compare it to. And then on the side here, I have a picture of what the project labels look like. So you're going to fill, RRMP, that's Ronald Reagan's site. It would be 001 and then today's date and then the location. And I'm going to go into detail on filling out that label, but you want to put the sticker on the patient's skin and then make sure that sticker is in the image capture. Yeah. And then, make sure you store your photos in a secure location and then it'll be uploaded to REDCap. Here are more tips for taking the photos. So you want to center the lesion in the middle of the photo frame. And, on your phone and stuff, you can tap on the screen, or if you have an iPad, you can tap on the screen. It'll kind of, clear and make it clear for that picture that's focus it. And then for cameras that do not focus well, when you get too close, you might want to just step back a little bit. And then if you're using an actual camera, you can use the zoom in feature. And then, you guys know how to use the iPhone zoom in and zoom out. Okay, so this is which lesions are going to be swabbed, which is the same thing as which lesions the photograph will be as well. So if there are greater than 2 lesion locations, so, there could be like 10, you only need to find 2 locations for this particular swabbing and photo. And you want to find the 2 locations that are most suspicious for Mpox. So anything per our definition, which would be vesicular, pustular, or fluid filled, that would kind of be the priority to find the 2 lesion locations. If there are 2 different locations and they have fluid-filled lesions, then 1 swab should be taken for each of those locations. So a total of 2 swabs are taken. So in this example, The first patient, the location A is 17L, and then in parentheses, I wrote right thigh on the label. And then the second location was 7R, which is the right back. So it's good to write the number per the diagram and then just a specific location in parentheses. If a patient only has one lesion location with fluid-filled lesions, then you're going to take 2 swabs of that one location. And in this example, 13L is written both for location A and for location B. And then if you don't have any lesions that are vesicular, pustular, or fluid-filled, then you're going to swab the lesion that is an ulcer. So preparing for swab collection, I know sites will differ between if study coordinators are doing the swabs or if providers, but you want to make sure that, proper PPE is worn. Use the research provided e-swabs, and I will be shipping all the supplies probably on Tuesday. So I hope that you guys will get them by Wednesday, probably Thursday latest. Vigorous swabbing of the lesion gives a higher chance of accurate results. Specimens that do not contain enough human DNA may lead to inconclusive PCR test results. Unroofing or aspiration of lesions or using sharp instruments is not necessary, nor recommended due to risk of sharps injury. And do not clean the lesion with ethanol or any other disinfectant prior to swabbing. So these are the steps to take the swab. So you want to hold the swab firmly and avoid touching the swab shaft. So at least 1 inch before the tip, and the length of the swab shaft that will be submerged into the transport medium. You don't want to have touch any portion of that. You're going to swipe the swab back and forth on the lesion 2 to 3 times. And then you're going to rotate it and turn it around. And then on the other side of the swab, do the same thing. You're going to go back and forth 2 to 3 times. While you're doing this, make sure you're applying firm pressure. So it actually might be uncomfortable for the patient and maybe a little bit painful, but this is important so that you obtain adequate DNA. They say that the pressure kind of must be firm enough so that it's almost like the plastic shaft might bend a little bit. So that gives you an idea of how firm the pressure should be when you're swabbing. If a lesion ruptures while you're swabbing, make sure that you collect some of the fluid. And then, if skin material is visible on the swab, this is adequate collection. However, skin material may not always be visible, so don't try to force that. Once you've collected your swab, so you'll have 2 swabs per patient, and each swab will have a location A and location B sticker on it. You're going to store those swabs in a -70 freezer or -80. If you don't have that, it's fine to store it in a -20. And then we're planning to have you guys ship the swabs every 2 weeks, around the 15th and the 30th or 31st of every month, usually on a Monday through Thursday if you can ship. We don't want any swabs arriving to the lab on Saturday. In my shipment of supplies, I've included a few FedEx labels for you. So the address of the lab in Los Angeles will already be on the FedEx label. And then for specific instructions on how to ship and dry ice and how to package it, please review the MOP. It has a lot of the details, and you can always reach out to me if you have questions once you're getting ready to ship. Once the lab tests the swabs, if the Mpox result is positive and the participant did not get an Mpox test as part of regular care, then Anusha and I will end up notifying the site of the positive result so that you guys can inform the participant about the positive result. And then this is a shipping form that's going to be used at the time that you ship the specimens. You can see that, you have to fill out your site name, the date you shipped it, and then your tracking number. And then the project ID will be the sample, the subject ID number for the patient, a location and location B, and then the description, which is written on the sticker, and then the date. And any comments, if you need to add anything about what happened during collection or anything you need to mention, you can say that in there. And once you fill this form out, you're going to put it in the shipping box, and you will also email a copy of it to Dr. Gardner, myself, and Anusha. That's it.
Does anyone have any questions for Cub? Oops, I'm going to stop sharing anyway.
Yeah, sorry, I have another one. I'm anticipating we'll get some patients that the lesions are mostly crusted or scabbed. I'm assuming just follow the same procedure and do the best we can. But we still want to enroll those patients.
Yes.
But yeah, as Cub mentioned, you wouldn't try to remove the scab or anything. Just do your best to swab as best you can. And also I wanted to mention here that some of you have already reached out to me about this. Some of you are worried about the picture, and that participants may not want to participate if there's a picture involved. And we just want to let you know that the picture is we want to try to obtain these pictures. We think that this information will be valuable to get some images of MPOX, but it's not required for enrollment. So if the participant is just not comfortable with you taking a picture, that's okay. But the rash swab is required.
And just to answer the question in the chat, yes. So if a patient only has a single lesion, you will swab it twice. The first swab, you'll put a location A sticker, and the second swab, the location B. It'll be the same, location. And if they have 10 sites, you're going to pick pick 2 sites and do a location A and a location B.
All right, I'm glad we made this an hour and a half, because we're at an hour now and we still have more to go. So I'm going to turn it over to Lorenzo to go through a brief description of the REDCap.
Thank you very much for the introduction, Anusha. Do we want to cover these top 2 points or top few points prior to doing the REDCap demo, or should we move back to it?
We can go back to it. So I'm going to stop sharing and you can go ahead.
Okay, I'll go ahead and share my screen. Go to the CRASH project. So in terms of the actual content of the REDCap, it very closely, pretty much exactly mirrors what Dr. Torres covered earlier. So for example, for the enrollment form, you can see that the homunculus that he described earlier is present. And so it exactly mirrors what you saw in the paper forms down to the numbering. So filling the forms out themselves will be pretty straightforward. So I'll mostly be covering 2 sort of unique aspects of the REDCap, the first of which is dual entry. So each form that isn't self-reported by the patient is going to be entered twice. And so for each form, except for the enrollment survey and the telephone follow-up survey, which will be used in the case that following 45 days, we're unable to contact the patient over phone call, we'll just text them a version of the telephone follow-up form for them to fill out. All of the non-self-reported forms will be entered twice, and the content of the A form and B form are identical. So we ask that you please just enter information twice over. It doesn't need to be by the same person or by different people per se. And then discrepancies between both forms will be analyzed by myself with the help of Dr. Bill Maurer. And so if we find any, we'll reach out to your site and ask for clarification if there's any sort of difference between the 2 or anything that doesn't make sense to us. And then secondly, for the enrollment survey, as we said, it'll be administered to participants. And I'd like to quickly show how we're going to do that. So to administer it, there's 2 ways we can do it. We can either do it by QR code or access code, or by email. So if you want to email it to them for whatever reason, you'd go to survey options at the top of the enrollment survey and select compose survey invitation. And it'll give you sort of a skeleton of the email. You can select the sender as well as the recipient subject. You can even send it at a specific time if you'd like, although if you're enrolling a patient, should be just sort of then and there. And then the other option, which I find a bit more convenient, is under compose survey invitation, there's the option to do a survey access code or QR code. So if you select that and open it, as long as the patient has access to a cell phone, they can go ahead and just scan this QR code and they'll gain access to the survey. And so it's fairly straightforward to administer it. An additional wrinkle to this is that because we're enrolling patients who speak both English and Spanish, we'll also want to administer the Spanish form to Spanish-speaking patients. And so in order to do that, when on the enrollment survey, you click this little globe icon and go to Spanish, and you administer it the same way, either by email or by QR code. And those who are paying attention to detail will notice that the response is here in English. That's due to an error that'll be resolved prior to the REDCap being launched at the middle of next week. And so following about like the middle of next week, upon your submission of the requisite city human subject training form, as well as the UCLA REDCap access request form, will get you and your research team access to the REDCap. That is my overview of the REDCap. Everything else should mirror exactly what Dr. Torres covered earlier in his coverage of the enrollment forms for this project. If there are any questions, I'd be happy to answer them now.
So one thing that a lot of us aren't used to is the dual entry of the forms. We've never done this for Emergency IDNet before, but as we move our data coordinating center operations to UCLA, Dr. Maurer is sure that this is the way to go, is to start entering the data twice. And the objective of that is to minimize error when we get to the analysis phase. So this is going to be a test for us. We've never done this before. And so I'm really interested to see how it goes. I know it's a little bit of extra work, but these forms aren't too long, thankfully, so it shouldn't take too much more time. And then the other thing is, for the survey options, we talked about that we could use an iPad, right? So for this, so Lorenzo, can you go into the survey options? So it's possible to just, if you have a study iPad, is that first one, log out and open survey. So you can log into your REDCap and then log out and open the survey, and it'll, it won't be in REDCap, so you don't have to worry about the participants seeing anyone else's records, and it'll just open the survey on the iPad, and they can just take it that way as well. So phone or iPad, or I don't think you'll be emailing at enrollment, but that's a possibility if we do set up the telephone follow-up as a link, then we could use it as an email option. So it's good that he showed you that. And then the QR code, if they want to do it on their phone, they can. It looks nice, and you can actually test it. And once you get access, you can see what it looks like on your phone and see whether it's something that would work. You can see for some of these questions, the responses, there's a lot of possible responses. So it may not show up that well on a phone, but you could test it out. Any questions for Lorenzo?
Okay, if there aren't any, I'll stop sharing my screen and we can go back to the presentation.
All right. And then, I think I already sent an email about this earlier this week. If you already have access to REDCap for other IDNet projects, just send me a list of the staff that already has access, and it's very simple to add you guys to the project. If you don't, then complete the REDCap access form, which is on the website, and send your latest human subjects training certificates, and then we'll get you added next week as well. All right. Couple more things. So All the IDNet sites are very familiar with this process, but we always do an audit of non-enrolled eligible cases. The reason we do this is because we do not have, I don't think any of our sites have 24/7 coverage of the ED. Usually it's business hours. Some of us have some coverage on weekends. But what we want to see is whether, how well we're capturing eligible patients, so our capture rate. Another reason to do the audit is to identify issues with our patient screening procedures. So I want everyone to try to set this up soon and look at your June data early so that you can sort of identify, where you're missing patients, if you're missing patients, and you might need to adjust your coverage hours. Our UCLA site actually started screening patients about 3 or 4 weeks ago, and they haven't enrolled anyone yet. And what they're finding based on, looking back, back screening and also checking records is a lot of the patients are coming in at night and on the weekends. So they're just missing they just don't have the coverage available. And if there is a possibility for you to expand coverage during this time, if you're seeing that, then we would want you to try to adjust. Another thing that we look at is whether there's bias in the patient population that agrees to participate in the project versus those that aren't enrolled. So the audit is very similar to our usual setup. It's, generate a monthly report. Hopefully you can do this through your EMR system very easily. Patients greater than 3 months of age who have any of the following ICD-10 codes. We actually, when we first drafted this form, our list of ICD-10 diagnosis codes were much longer. So I ran it for April at our site and I got 341 records. So we cut the list of diagnosis codes down to these ones. And this ended up with about 140 records. So a little bit less work. But I do think that, again, this is broad surveillance. We want to try to capture the people that we're missing as well. So hopefully it won't take too long. But remember, what you'll do is get that report. You'll remove the patients who don't meet inclusion criteria. So looking through their EMRs, seeing if they have a rash that qualifies. And for those that do, you would fill out the enrollment, the audit form. And there's detailed instructions on the form on how to assign each patient an audit ID. And then that'll also go into a separate REDCap data entry module, which you'll also have access to once we're ready, hopefully by the end of next week. Any questions about the audit? All right. Almost done. So again, we talked about this before, and I think all of you sort of have a communication system set up that you use. But we encourage you to meet with your team at least weekly, especially initially during when you start screening, and meet with your site PI, talk about the barriers that you're encountering. If you want one of us to sit in on one of those meetings, please reach out, text me, call me, and we can help troubleshoot early on. We want to capture anything that's not working early on, right? This is a short surveillance period. It's 6 months. So we really need to be on it initially. If you have the ability to set up a group text, I also highly recommend that. And then we thought that it'd be good, and this is not sort of a formal communication, but we thought it'd be good for all the sites to give their hospital infection control folks just a heads up about the project. Just let them know that we're doing this. And if they do hear of any cases, and we might hear about cases before they do, or vice versa, and they'll be probably working with the state. to just give us a heads up so that we also are aware of what's happening in the patient population. You don't have to share information with them if there's any issues with sharing data and things like that. It's more of an informal communication, a heads up that we're doing this project, and just if they have questions, or if they see a case and they have questions, they can kind of reach out to you, and there can be some communication set up. All right, next steps is set your launch date. I think for most sites, because you're not going to get supplies until next week, we're not going to get you REDCap access until next week. So maybe next Friday, most likely June 5th would be the earliest start date. But if you can start sometime that week, June 5th to the 9th, that would be ideal. And again, we want all sites to start at the same time. So I'm hoping that we can get these last pieces from some of these sites done in time. In the meantime, you might want to test your audit procedures, test your screening procedures next week. You start looking at the ED tracking board, seeing what you see, looking through triage notes, just to get an idea of what you're looking for. If you have any questions, you can reach out to me or Cov. If you have questions about the REDCap, you can always reach out to Lorenzo. And then all the project materials, we're trying something new again this time, is going to be available on the website. This was always the dream. The only thing that is hard about this is we lost our website designer. So you guys are stuck with me. And I'm just going to flash this up. So this is our IDNet website. It looks nice. I didn't do any of this. And we have our crash project here, and we have a little description here. And then if you scroll down, this is my attempt to put everything on one slide, one page. It doesn't look pretty, but it's functional.
I'm not
So
seeing
the
your screen anymore.
Yeah, you're not sharing at the moment, Anusha.
Oh, sorry, I lost you guys. Okay,
We see you.
There we
You're
go.
not sharing.
Here we go.
There you go.
Okay, so this is our website. Looks nice. If you go to current research, you'll see all some of our projects here. Crashed is one of them. If you scroll down, all the documents are here. So I have the project proposal, the MOP, the training slides from today are already on here. So you can click on here and download them. The specimen shipment form, REDCap access form, audit, the example of the posters on here, and then all the data collection forms. And there's the Spanish versions here at the bottom. So right now, I know that some of you have started to put together the packets. I ask you to hold off on that until middle of next week, and I'll send you all an email when everything is updated. We had some last minute changes to the enrollment data form and the telephone follow-up form. So I'm going to make those changes and also adjust the Spanish versions and put them on the website by next Wednesday. So just hold off on downloading those ones in particularly, but all these other ones, go ahead and access as needed. All right, I think that's the end of the training. Are there any questions? Check the chat. Yes, so Amy, the slides are already on the website. And Mastura, I do have time to chat after this about the IRB request. Any other questions? All right, well, you guys know where to find us. Thank you, Greg, Jesus, Kavita, Carl, Lorenzo.
Thank you.
Thanks, Frank. Thanks for joining, and we'll be in touch.
Thank you.
Thank you.
Thanks, everybody. Bye.
Have a nice weekend.
Have a good one all.